it's good to talk about influenza, pneumonia, Omicron. I think this is a really good topic, and I think we can hit the highlights. Well, I don't think this will be too long today. I think it'll just be kind of the bullet points, just high yield stuff. And so, if you have any questions or anything, please put it in the chat.
I know it's holiday season, so everybody's busy. So we'll send out the recordings after. Okay.
All right, so we're going to go over influenza first, and then we'll move into pneumonia. Then we'll go into what's known about Omicron. So influenza, we got this from the latest information. These are the key updates for this. It says week 46, ending in November 20th. So this is the most recent influenza surveillance. This is all through the CDC. This is through the CDC. Their surveillance information. And so viruses, there isn't a lot of influenza around, and there wasn't last year. And then we'll see some of that in some of the graphs. But
I did see it last year. I didn't see a single case of influenza.
Yeah.
That was confirmed.
I didn't see influenza, and I also didn't see West Nile for some reason. There's no West Nile. Well, RSV, did you see RSV last year? Yeah, I think the lab, the Omaha VA lab had one, I think and there was a false positive, I think. so there wasn't any influenza really positives last year that I saw, or that any patients that I saw. Now, clinical lab, so 1% positive for influenza this week. So we'll look at the graphs, and it looks like it may be, it's just starting and maybe starting to rise, but not much in the way of positive so far. So this is the graph. You can see it's just starting out. So normally as the flu season goes on, the whole graph turns slowly red, and then the graph the whole country is red. But you can see how it looks right now. It's just starting out. 2.2% of visits to a healthcare provider for influenza-like illness, and so these are, things that look like it could be influenza, but not always proven. And just essentially people show up with myalgias, fatigue, symptoms of influenza, and they call it influenza-like illness.
No, can you guys hear me okay? Jackie, am I able to hear me now? Oh, are you able to hear me now?
Oh, good. Okay.
Thank you.
Oh, and then, sorry, long-term care facilities. This is 0.2% of facilities reported at least one positive test. So not very many care facilities have influenza so far. And severe disease. So this 14.5% mortality, this is deaths attributed to pneumonia, influenza, or COVID. So it's capturing all three, and this is above threshold. This is high. Pediatric deaths, 0 so far. And some of the key points: influenza is low nationally, but in recent weeks, the lab confirmed influenza detections and outpatient visits due to influenza-like illness are increasing. And we will look at the ages. We have a graph looking at the ages, but most of them are in children and young adults 5 to 24 years old.
So this influenza variant has higher degree of bacterial pneumonia as well.
So influenza positive tests reported to the CDC by US clinical laboratories. And so this is essentially showing influenza A is most of it, and then influenza B is just a small little bit, but it's mostly A.
We're hearing a lot of, can you guys hear us now? Yes, okay. We'll sit very closely. Is this better, Jackie?
Yeah,
Okay.
we can hear you.
Okay, perfect. Thank you, Samaya. Go ahead, John.
So it's mostly A. And then continuing on, this is influenza-associated pediatric deaths. And so you can see in the 2021 season, there was only one pediatric death. And then, so far we haven't had any, but and that's due to the low levels of influenza last year.
I'm not even sure this one pediatric death was really truly influenza because it was such a
Yes,
low incidence.
it'd be really odd to have just one. And then here, this you can see the triangles, the red triangles at the start. Let's see. So here are the red triangles. This is this year. This is 21 to 22 season. And you can see we're just starting out, and then we'll see as the season progresses how this turns out. Hopefully it stays low again if everyone's wearing masks and distancing and everything. But as masks come off, this might increase and go very high like the previous seasons.
Yeah. Hope it stays low, but we'll see. I hope with masks it'll be able to keep it down because I am worried about winter and all the viruses back in the community.
And then here, this is influenza-like illness by age groups. And you can see, this is what we were just saying a second ago, that this is, let's see.
0 to 4.
0 to 4. And then this one down here is 5 to 24. So the age groups that are starting to have positives are, the younger population.
It's influenza-like illness. So unfortunately, this could also mean they could be having COVID-19 too,
right?
Because, same symptoms.
And this is hospitalization. This is hospitals reported confirming influenza, and you can see it's very low. So hopefully it stays low. And then here we have long-term care facilities, also low. And as far as influenza testing, now I think it's still a good idea to talk about this since we haven't seen influenza recently and to kind of review, it's been a while since we've seen an influenza patient, but PCR is preferred over rapid tests. So if you have the option of using a PCR test, that would be best. And, once there's an outbreak, if everybody is coming in with influenza, then you don't even really need to test. You can essentially just treat them for it. And that's, if you're not sure if they also have influenza, if they're coming in with COVID, they could have COVID plus influenza.
Yeah, I'm hearing about cases currently where they're seeing both across the US. I haven't seen it personally, but patients are getting both at the same time. The PCR is best, and in your institution, if you have combined PCRs, now they have something called the full plex, where it picks influenza A, B, COVID, and RSV. If you have that tool, like using it in the emergency room clinic, to be really helpful. Otherwise, you have to use separate tests to be able to figure out what's going on.
Yeah, I mean, if you have overlapping COVID, high rates of COVID and influenza, if you're not sure, if you can't test them right away, I think you were saying earlier to give them treatment for influenza while you're waiting for that to return, or just treating them for it, right?
That's a really good point. So we get asked a lot, what do we do now that, we have COVID-19 and influenza season, right? So in your community, if you start seeing the influenza rate goes up, I would say you test them. While you wait for the test, give them Tamiflu, right? It can be influenza. So give them Tamiflu if your rate of influenza in your community is high, and wait for the test back. But unfortunately, we have to test for both now because there's no way to say which one is which. As far as rapid influenza test, if it's positive, I guess that's good. But if it's negative, that doesn't rule out influenza.
And then as far as treatment, it's still important to give people treatment, even if it's past 48 hours, if they're in the hospitalized or if they're severe. I would add to this, or if they have COVID also,
Yeah.
if they're if they're hospitalized, or they're going to be treated at home, kind of evaluate the patient, see how many comorbidities they have, see what you think their risk is. If they have a high risk, then I would essentially treat them even if it's outside the 48-hour time period.
Yeah, and CDC actually says this in their guidelines too. Like for me, high risk patients if they get influenza, like if you have COPD, asthma, pregnant patient, right? Or if you are like cancer patient on chemotherapy, they all fall into the high risk category. So even if it's post 48 hours, please consider giving Tamiflu. It's going to decrease that viral replication.
And then as far as influenza treatment, so we have oseltamivir. Oseltamivir is really, the best thing to use is better than zanamivir, which is inhaled. There's Primavir, which is IV only, and Baloxavir, which is pills. But really, oseltamivir is the go-to.
Out of all of them, you're right. Tamiflu, oseltamivir is a go-to. Baloxavir, I believe it's more expensive. So if you're being stewards of cost and giving the right treatment, Tamiflu works. So I would do that.
Now, what if you're exposed to a family member? So people say, they were near somebody else that was found to have flu. Then we would recommend getting the flu shot and Tamiflu. So, we would recommend the flu shot anyway, and getting kind of ahead of it and getting the flu shot now would be a good plan. And as far as and that would be considered chemoprophylaxis. So if someone, you hear about a patient that contacts you and says that, their family member has influenza and they've been around that person, but they're feeling okay, it would be okay to give them something to prevent infection, to prevent them from getting influenza. And that would be something like oseltamivir, and then you would give it for 10 days. And this also goes for outbreaks in settings like nursing homes and things like that. You can essentially give it to everybody.
I think sometimes we get confused about duration of treatment for treatment versus prophylaxis. Treatment is 5 days, prophylaxis is 10 days.
And then as far as influenza, and then getting into community-acquired pneumonia or secondary bacterial infections on top of influenza. And so you can also think of this not only for influenza, but other viruses like RSV, even COVID, if you're going to get a bacterial infection on top of a viral infection. So in the outpatient setting, inpatient ICU, strep pneumo is number one.
Yeah, strep pneumo always. But then with influenza, especially the strain that is in the community H2 and 3, from the influenza A, it's known to cause strep pneumo plus MRSA, MSSA pneumonia. So making sure if somebody's coming in that they have recent influenza and they have bacterial pneumonia, we should be covering for both.
And so these are the American Thoracic Society or Infectious Disease Society of America recommendations with regard to community-acquired pneumonia. And this is just kind of for your reference, so you can look through it afterwards if there are any questions, but it goes through the new updates versus what was covered in the old updates. I do want to highlight that use of procalcitonin, you wouldn't use it to start treatment. So if someone comes in sick and you get a procalcitonin, it's low, if you are feeling like you're going to give them antibiotics, well, the low procalcitonin shouldn't dissuade you. You shouldn't change your mind based on a low procalcitonin. I just wanted to point that one out.
I always say it's not diagnostic for pneumonia, it can be a prognostic marker. So if it's elevated, you could follow it and make sure that you're treating the patient appropriately and they're getting better.
And then the other one I wanted to point out was that the use of corticosteroids. So, I feel like I frequently see people coming in and they're on steroids, they're on prednisone for a pneumonia. And some of these patients, I have seen a few where they come in and they've been getting an antibiotic plus prednisone, and then they're diagnosed with something like COVID, and then they're put on high dose steroids, but they've already been on steroids for a while when they come in and they get it turns out being kind of prolonged steroid use. But for just a typical community-acquired pneumonia, I don't traditionally give steroids or prednisone.
Unless they're having like COPD exacerbation or something like
Right,
that.
unless there's another.
Yeah, I can't see the utility of steroids with community-acquired. I completely agree. I think that's just going to put the patient on getting other infections.
Right, including fungal infections. You know, in those patients that get prolonged steroids, sometimes they'll get a fungal infection, and so community-acquired pneumonia or pneumonia in general alone, I wouldn't give prednisone or any steroids. And then in adults with community-acquired pneumonia who test positive for influenza, should the treatment include antibiotics? And so this is something that I think is a good idea. Not only antibiotics, but something for MRSA coverage as well. Yeah.
Doxycycline, you could use that. Doxycycline has over 90% susceptibility to MRSA. Bactrim, if the patient is young and the kidneys are okay, you could do, but unfortunately, Bactrim doesn't cover atypical. But doxy and ceftriaxone works really well for community-acquired pneumonia. Only thing, the other things that you can do, sputum culture, right? It's so helpful. I think we don't get enough sputum culture that could really tell you what organism. For some reason, if you cannot get sputum culture, you could do MRSA culture of the nares. So certain places you could do rapid PCR tests like the VA. You get the results back in like an hour, and you know that if they have pneumonia, if the MRSA nasal PCR is negative, most likely you don't have MRSA pneumonia, right? So if you have this in your hospital, either getting a culture, which takes 24 hours, PCR an hour is really, really helpful.
Now, as far as these prediction rules, it was recommending the pneumonia severity index score, but and because there was recommending the pneumonia severity index score for the curve 65, because it's more able to predict what's happening with the patient. But there are so many things that go into the pneumonia severity index score. I personally just use the curve 65, and the curve 65 is used to place patients. So instead of subjectively how sick are they, where should they go, and having one clinician say one thing and another say another, you can use curve 65 to see if you can treat them as an outpatient, as an inpatient, or inpatient ICU. And some of the things that they look at when it comes to how sick are they look, here's the minor and major criteria. Now, minor criteria, there's a lot, and major criteria, there's septic shock and respiratory failure requiring a ventilator, which I think everyone knows of those major criteria. And then going forward, this is the outpatient setting, which antibiotics are used. So it says with no comorbidities, and I don't know that I've seen any patients with no comorbidities, but amoxicillin or doxycycline or macrolide, and then with comorbidities, amoxicillin clavulanate or a cephalosporin and a macrolide or doxycycline, or monotherapy with a respiratory fluoroquinolone.
I would just say, the macrolide, we see a lot of azithromycin being prescribed for pneumonia in the outpatient setting. I think a lot of places, the resistance is close to 40 to 50% azithromycin to strep pneumo. So it should not be, in my mind, used monotherapy, and really important to look at your antibiogram. So I like amoxicillin and doxy, but it makes me really nervous with strep pneumo and azithromycin. In our area, it's over 45, 50% resistant to strep pneumo. So yeah.
Oh yeah, I completely agree. I would rather give a cephalosporin rather than macrolide.
Yeah.
And macrolides, I mean, azithromycin has a lot of gram-negative coverage. A cephalosporin, I think, would be preferable over a macrolide.
Comorbidities, then you could add macrolide to a cephalosporin, for atypical, like mycoplasma right here coverage if you want, a chlamydia. So I usually use it for the atypical coverage.
And then in the inpatient setting, when antibiotic regimens are recommended for empiric treatment of CAP in adults without risk factors. So this is going to be a beta-lactam plus a macrolide or respiratory fluoroquinolone. And then severe is going to be a beta-lactam plus a macrolide or a beta-lactam plus a fluoroquinolone. And then as far as checking for MRSA, they kind of switch the recommendation from, if they've had prior MRSA, and they kind of switch it by saying, check, if they're not too sick, check, and if it's positive, cover, or if they're really sick, cover, and then check to take it off and to reduce it.
I just love how they have added this into the guidelines, and I think we have so much opportunity to do this. So we do so much vancomycin use in our hospitals, and this will really help with reduction of vanco use and AKIs that we see in our patients.
Yes, and then patients, so when starting vancomycin for pneumonia, if you also check their NARES and their NARES are negative, that can be used to de-escalate and stop the vancomycin. Yeah, that's a great point.
Yeah, and it'll only take you 24 hours if you don't have the PCR. Even the culture should come back really quickly. So consider incorporating that into your practice at your facility.
Yes, and this is a very good intervention that some of the hospitals that we work with have used as an intervention to, anytime vancomycin is started for pneumonia, check the NARES, and if negative, stop the vancomycin. And that decreases the amount of vancomycin that's used in the hospital, and that's a very good intervention. Yeah. And then here we have severe and risk for resistance. Now, this is going to be kind of similar, where if it's non-severe versus severe, if it's severe, you would start and then you would check cultures and de-escalate accordingly. So, but it really depends on your hospital and rates of resistance within your hospital.
If you're worried about Pseudomonas, I think empirically really important to look at your antibiogram. So if I look at our facility antibiogram, we have over 94% susceptibility to pip/tazo, 94% to cefepime. So those are really good go-tos, and levo is only like 75%, right? So I think it's really important to kind of take a look at your antibiogram. I always tell my learners, it's like a cheat sheet you have right there. You can figure out which one to start. That really helps you.
And then as far as duration of treatment, no less than a total of 5 days. So we do recommend 5 days, and if they're doing well, they're improving, then you can stop after 5 days.
Otherwise, you could do 5 to 7 days, but I don't think you need longer than that.
And that's really good. Even even in patients with COVID, if they're doing well, it's good to stop and then reevaluate and see how things are going. And I'll tell the families that we can always restart if needed, but it's a good idea to kind of decrease those days of antibiotics if possible. And this is a good chart. This is pneumonia, influenza, and COVID-19 mortality. And then you can see how high this is compared to the usual, essentially. The expected, and then here the yellow is going to be influenza. So you saw yellow here, and then 2019, 2020, and then it disappears. And so this isn't caused from influenza so much. This is mostly COVID and then pneumonia.
It was really shocking to see this slide. Dr. Horn was showing me this slide. We pre-pandemic, we knew the mortality with influenza, but if you look over here, even though we had it was so low compared to what we're seeing now. So it was a very powerful slide.
Right, and there's another slide that actually, when COVID first came out, they were looking at mortality from COVID and then unexplained deaths. And unexplained deaths were very high, and those must be related to COVID as well. And those, whether they're from MI or from strokes or from something else, MIs and strokes go up when people have another infection on top of it, and that was shown with zoster. And people get zoster, and then their strokes and MIs go up. And so even if someone dies from an MI, it could be related to COVID because, but generally the COVID numbers are lower than reality, really.
I'm not sure what you all are seeing in your hospital setting, but with Delta, I say Delta is very different from the early Alpha strain. We're seeing a lot of mortality with young people, 28, 30, 32, 35. So I think anything that we all as a community can tell our community get vaccinated, and it's going to be really, really important.
The Omicron. So this is what we know so far. And this is early November, an increase in cases noted in South Africa, Johannesburg, and the initial cluster was among university students had been on a bus trip, and the whole genome was sequenced, and they noticed it was novel. They noticed it was something new, and they said that it had been detected so far as of November 28th in Botswana, South Africa, Hong Kong, Belgium, so United Kingdom, Israel, so it's all over already.
Yeah, it's now in Canada too. So I think travel bans and things like that is not going to eliminate the variants. Unfortunately, I think it's a very, very, very temporary measure. The best thing we could do is to get people vaccinated.
Yep. And then Johannesburg had a significant increase in cases from about 300 a day to 4,000 per day, but not yet an increase in hospitalizations. So that makes me hopeful, right?
Yeah, exactly.
But not yet sure if Omicron is more severe, but some breakthrough infections are occurring among vaccinated individuals. And then among the young, the symptoms have been mostly mild, and it's likely emerged from an HIV-infected individual with a very low CD4 count, and he was not on HIV treatment, and he was COVID positive for over 200 days. So, I mean, that's pretty interesting. So essentially the virus is replicating in this person and changing and then spread. And so this is the thought that it probably came from this person, which to me is very interesting, right? It's unfortunate, right? So really, everyone with HIV and should be on treatment and for the best thing for them.
Yeah.
It also shows best thing for the community as well. Yeah.
There's a lot of struggles in developing countries.
Yeah.
But what I am really reassured is that I know there's a lot of concern right now with Omicron, but we have had a lot of variants. We know what works. I think making sure we communicate masks work and getting vaccination. And I am really glad that, mild infection is what they're seeing. But even though it went from 300 infections to 4,000 in Johannesburg, we also have to consider the vaccine rate in the country is really low too. Yes, so they could just have rapid,
That's true.
So it's hard to say. There's more to come. We'll learn more. But I think we have to send the message, every single one of us, letting our friends and family and community get vaccinated and wear a mask.
And preliminary tests indicate COVID-19 antibody drug cocktail from Regeneron loses effectiveness against Omicron. So, and I think that this is information just came out today that Regeneron did their testing and they said that loses effectiveness. Eli Lilly also said that their drug cocktail loses effectiveness with Omicron. And Omicron contains mutations to the spike protein that the Regeneron and Eli Lilly drugs target.
We still don't know about BAM-EDI combination yet. But again, I think it might lose effectiveness, but that doesn't mean
So it doesn't mean ineffective.
Ineffective, exactly. So it might go from I don't know, making this up 80% to 70%. So we still have more to learn and hope we get more data. But for now, in the outpatient setting, if you have mild to moderate infection, please use the monoclonals that we have. But I think we'll learn as how much effectiveness we're losing is going to be important to know.
Right, and I would still, like you're saying, strongly encourage vaccination as the best thing. And this also means that there are multiple drugs now, and this is just what they're coming out with, saying from a perspective of the spike protein that's changed. But there are other things such as steroids and things that target other things besides the spike protein.
Yeah, this is when you get admitted to the hospital, we have steroids. We have cytokine inhibitors like we all been using, like Toci and baricitinib. And we also So we have those agents that have shown to decrease mortality. This is in severe cases, right? The best thing we could do again
Yes, is
vaccine
vaccinate.
and wear a mask indoors when you're in large crowded places. And booster, this was updated yesterday. So initially, we have had lots of different recommendations from CDC, step-by-step fashion, especially now with Omicron. What they're recommending is anybody over the age of 18 should get booster vaccine. If you receive J&J, you should, after 2 months of receiving J&J, you could get an mRNA booster, either Pfizer or Moderna. If you receive the mRNA vaccine as your series, then 6 months after receiving the last dose, you could receive another mRNA. Another thing is they're saying you could go get whichever. So in some communities, you might have received Pfizer, but now what they have is only Moderna. It's fine, just get the Moderna. Whatever is convenient, whatever you have, you could get that, is kind of the message.
Right, and the Omicron, all the concerns about that, first that would have to become the dominant, it would have to overcome Delta in our area. So I wouldn't do anything differently right now. And then also that, when it comes to monoclonal antibodies and things, it doesn't mean don't use it, as we were saying.
Yeah.
I want to just stress that we're not saying to do anything differently right now.
So please use the monoclonal for mild to moderate disease. And outpatient. There's some good news. I'm still waiting. I think in a week or so, we probably get the Molnupiravir. It's the antiviral directed at SARS-CoV-2. So that might come into play. So we might have another tool in the outpatient setting. Here's 5-day course, take by mouth in mild to moderate cases. So waiting to hear about that from FDA. And inpatient, we also have treatment, but best tool is vaccine and masks.
All right, great. So if there are any questions, please send us any questions that you have.
Yeah, you could type it in the chat or you could unmute and ask us if you guys have any questions at all. Happy to answer.
All right, great. So thank you for joining us.
Thank you so much.